Okay, can you see my screen? Could someone answer?
Yes po, Doc. Kita po.
What do you see? Can someone describe what you see? Para I know I'm sharing the right screen. You have no feedback here.
Doc, there's a red star po sa right bottom corner and then may long blue arrow
Okay,
pointing.
thank you. You're on the right page. So the lecture today is scheduled to be from 8 to 10 in the morning. Just go slow because the subject matter is packed with information. But the reason why I'm showing you this screen is so that you are guided. Whenever you see the red star, that means it is something that we'd like you to remember and put emphasis on. So don't forget to look for the red star. Understood? Okay, you need to respond. Kasi otherwise I might log out pag wala nang sumasagot. Okay? So, true or false, Delgado Bianca, IOP is the only modifiable risk factor in primary open-angle glaucoma. Can you answer? Not on the chat, but just turn on your mic. Delgado, are you there? Can someone text Delgado Bianca? You have to answer right away so we can move. We have a lot of slides today. And you have 3 lectures for this week that you have to cram and prepare for. Can someone answer for Delgado Bianca? IOP is the
Hello,
only
Doc.
modifier. Yes, yes. Very
Hello
good.
po. Sorry, am
Yes.
I audible po?
Yes, I can hear you.
Doc, I think it's true po. Because the other the other risk factors are age, corneal thickness, something more on factors that cannot be modified. So I think
And that's correct.
the
Very good.
intraocular pressure is the only
Yeah,
modifiable
that's
risk po.
correct. Very good. And especially genetics, because this is a hereditary disorder and you cannot choose your genes. But eventually, probably through gene therapy, we can modify, not yet now. Okay, so that's correct. The answer is true. Okay, so there have been many studies on looking for ways to empower patients. Aside from us doing all the work, patients would like to know what they can do at home. And this is where mindfulness meditation comes in. It is a mental training practice that teaches you to slow down racing thoughts and let go. So in a way, you're trying to relax, meditate, and based on studies, and this is a randomized controlled trial long time ago before the pandemic. So they found out that mindfulness meditation reduces intraocular pressure, lowers stress biomarkers, and modulates gene expression in glaucoma. And this is an RC. So let's go to that. It can lower pressure as much as 2 points, 3 points. So if your pressure is 23, it goes down to normal. Not so much, but it helps. Okay, among other things. So everyone, let's try. This is 5 minutes of mindfulness meditation. Turn on your mics. Don't need to turn on your videos. Just listen, and hopefully we can put you in the right mind frame.
To begin this mindfulness meditation, just let yourself get into a comfortable position,
Can you hear it?
whatever that looks like for you.
Can someone answer? Is the audio okay?
When your body feels ready, you may gently close your eyes.
Can you hear the audio?
Yes po, Doc.
Okay, so just follow. It's just 5 minutes.
With your eyes closed,
So, oh, screen share.
take a moment to tune inwards. First, simply noticing your body, tuning into the weight of gravity, the points of contact between you and the surface on which you are resting. What else do you notice? What is it like for you to be in your body right now? As you observe this, you simply accept and allow whatever it is you notice, harboring no judgment, just being mindful, noticing what is with a sense of compassion in your heart and letting it be. Continue to do this now with your breath as well as your body. If you haven't already, begin to tune into the sensations of breathing. What do you notice? Just observe, accept, and allow. No judgment. Just letting everything be how it is. As you stay mindful of your breath and your body, with a sense of compassion in your heart. Keeping your eyes closed, you allow your awareness to expand to include the space around your body. It's as if you can sense the air around you, the objects around you, and you just allow them to be as you simply are. There's nothing to do, there's nothing to judge. If your mind wanders, that's okay. Don't judge it. Just return your focus to what is. Being connected to your breath, your body, and your sense of presence in the world around you. You let everything simply be, including yourself. You now begin to let your attention travel back, becoming more and more aware of physical sensations by rolling your shoulders, wiggling your fingers and toes, still being mindful of what is, and taking this present moment awareness with you as you slowly begin to open your eyes back to the world around you. Wonderful job doing this practice. We hope you enjoy the rest of your beautiful day.
Okay, and I promise you that you immediately feel better now. Okay, did everyone sign the chat box? Can you still hear me o tulog pa kayo? Can someone reply?
Yes po, Doc.
Okay, o gising na. Okay, so good morning. I am Dr. Leuenberger. I'm one of the faculty of PBR College of Medicine, and I'm the head of the department. And I'm also practicing at the Asian Eye Institute and member of the Glaucoma Society, and also graduated from our beloved UERM in 1991. So just also to inspire you, it's been a long journey, but I've devoted my life to the care of glaucoma, and ever since I finished my fellowship at Massachusetts Eye and Ear. So kayang-kaya natin yan. Just pass the MLE, even if you're not capable or not fortunate to pass the MLE, kaya pa rin. So if you can look for me there, this is just one of our photos during our fellowship at Boston. Okay, look, there were two of us from the Philippines, and the other one also owns an eye center here in. Okay, so here's what a glaucoma patient sees. This is how they view the world. Just a reminder that we will be going through the slides, some of it very quickly, as we assume that you went through the asynchronous video, and hopefully you read the past transcriptions, and hopefully you can answer the questions for the second long exam correctly. Okay. So here's the outline and learning objectives. Start with defining glaucoma, history taking, examination of the eye, glaucoma. Then we take a short break because this is a long lecture. Then we discuss the pathophysiology and types of glaucoma, and we go to treatment. So let's go again. Okay, true or false? I can get glaucoma even if my IOP is normal. So I just have to ask for volunteers, but you have to answer quickly. So we have to move fast. I can get glaucoma even if my IOP or intraocular pressure is normal. Can someone answer? Okay, you volunteer someone and answer quickly. I can get glaucoma. Ayoko naman magtawag. So just volunteer, state your name, and then answer. Okay? This is not graded, so just venture a guess. Anyone?
Hello, Doc. Good morning
Yeah.
po.
Your name?
I'm Anya Dael po.
Okay. Okay, Anya.
I think that the question is true kasi there's such a thing as normal pressure or low tension glaucoma.
Okay, very good. Is your first name Anyo?
Anya po, sorry.
Anya, sorry. So Anya, sorry, Anya. So correct. There is such a thing as normal pressure glaucoma, which means that you can still get nerve damage, visual field loss, even at normal eye pressures. And we call it normal pressure glaucoma or low tension glaucoma. It's very prevalent in Korea and Japan. So here in the Philippines, not so much, but in other Asian countries, especially Korea and Japan, it is quite prevalent. Okay. So let's start with a case. This is a 51-year-old district engineer who complains of frequently bumping into things on the left side for 7 months. And this is your typical board question that is asked of ophthalmology residents when they take the diplomate exam. So what questions will you ask in the history of present illness and past health history? Anyone? Well, are you from section A and C? Can someone answer? Kasi kaunti lang yung nakasulat dito sa attendance natin. 36 lang ba kayo? But there are 197 logged on. So not all are present. So make sure that you complete na ba ito? Anyway, Maria Zarina Beltran from 3A. What questions do you want to ask from the HDI and
Doc, I would
Hmm.
ask po for kung nahihirapan po ba sila makakita po or if may eye disturbances po sila.
Okay, the main complaint is frequently bumping into things on the left side for 7 months. So, kung nahihirapan sa vision or may blurring of vision,
Yes
ang
po.
sagot doon, wala. Malinaw yung vision. Ano pang questions ang puso mong tanong? The usual history taking. History of present illness questions. You don't need to ask all. Kasi remember the topic is glaucoma and you want to make sure it's not any other disease condition. Trying to rule out other causes and zero in on glaucoma. So, ano questions?
Doc, for ano po ba? Kapag redness po or
Redness,
magkaka-headache po yung patient
headaches.
po.
Okay, good. Next, ano pa? Kausap mo yung patient. You'll be clerks in a few months.
Doc, pwede ko rin po matanong kung may glasses po siya or
Okay.
if may
Wearing
strain na po
glasses.
siya ng... Yes po.
So what will cause you to lose sight of your left field of vision? Ano mga questions that you should ask to rule out other causes that may contribute to difficulty in seeing the left field of vision? Headaches? Now, if you ask headaches, what are you looking for? What are you trying to rule out?
Hello po, Doc. Try ko lang.
Yes, Xavier. Yeah.
For the headaches po, we would be trying to rule out migraines po ba?
Migraines. Okay. But this is 7 months of constant bumping into things. Ganun ba ang migraine? Yeah, it can be headaches with difficulty in seeing the left side will usually point to A. This is constant. Kasi migraines, usually may aura. Then when they start to get nauseated or actually vomit, nawawala. They usually are bothered by disturbances in vision, but it goes back to normal. So when you have a permanent loss, the left field of vision.
Hello po, Doc.
Yes.
I think for
Ano?
asking about headaches po, as well as history of hypertension or diabetes, we could try to, or cardiovascular effects, we could try to rule out stroke.
Okay. So, but usually stroke, there has to be some kind of motor deficiencies or speech. But you're pointing towards a neurologic problem. So aside from stroke, we're on the right track. Aside from stroke, what can contribute to headaches and dimness on the left half of vision? Anyone?
Doc,
Yeah,
maybe asking about headache is to rule out angle closure glaucoma.
okay. Yes, can be glaucoma. It's correct. What else? Cassandra Tan.
Hello, Doc.
Yes.
I would ask also if there's the patient is taking medicines because there are some medications that can cause if adverse effects sa vision po.
Yeah, such as.
One thing is the ethambutol, as said
Okay,
in
very
the
good.
articles po.
Which is medicine for. It's given for ethambutol. Yeah, there's such a thing as ethambutol toxic optic neuropathy. So that's correct. And it's given for, it's an anti-COX medicine. So you have to also include that, but mainly for headaches and for neurologic, we have to add a possible spatial occupying lesion expressing on the visual axis. Okay, so let's add to that.
Doc, if I may po,
Yes, yes.
one of the things that I would also ask for
Mhm.
in the HBI or past health history is if there is any history of comorbidities or even family history of blindness po.
Okay, very good. Because this is the age when most of the diseases for adults start evolving and start surfacing. Very good. Nice. Trauma, yes, from Daniela, correct. Accidents, trauma, inflammation. Okay. So the onset is gradual, painless, no trauma. So most of the time, most of the items here are already mentioned. And of course, ask for glasses, screen time, maintenance meds, surgeries, hospitalization, and eye drops. So this patient is nearsighted and has been wearing glasses since high school. Okay, so additional information. Vision is 20/20 on both eyes. Is that normal? Anyone? Normal by 20/20.
Yes po, Doc.
Okay, so you're correct. What about the pressure? Intraocular pressure, right, 15 millimeters mercury, and left 42 millimeters mercury. Anything abnormal? Are they both normal? Anyone?
Abnormal po yung sa left, Doc.
Okay, Alonso. Yes. Why? What is the normal pressure?
10 to 21 po yung normal range.
Okay, very good. Okay, so just keep your mic on. Can you describe the optic nerve of the right eye and the optic nerve of the left? Yeah, Alonso.
For the right eye po mukhang ito po yung mas normal. Then for the left eye po, mukhang very dilated po yung disc.
Okay, so maybe just a choice of words, no doubt that we're talking about glaucoma. How do you describe correct? No? So for the right eye, looks normal. The disc margins are well delineated. Well delineated disc margins, so that's where you start. The cup disc ratio is what, Alonso? So it's like a donut. So you see the nerve, looks like a donut. There is the outside rim, and there is the central hole or the hole of the donut. And you measure the cup in terms of percentage of the whole donut. So if you look at the cup, just eyeball it. What percentage is the cup in relation to the whole nerve, Alonso?
If
Take a
I were
guess.
to,
Yeah.
if I
If
were
this
to,
were a donut, ilang percent yung butas?
siguro po around mga 60 or 70%.
Okay. Close. Most would say 50%. So, but that's close. Is that normal? So if you have a 50% cup, in terms of cup disc ratio, what is that? In terms of decimal. A 50% cup, in terms of cup disc ratio is
0.5 po.
0.5, correct? Alala mo pa yung math mo. Okay. What about the other eye? Is this normal, Alonso? So again, you
For
describe the way we describe the right eye, you describe the left eye. Kayang-kaya mo na yan.
So, for the right eye po, so mas normal po siya since mas mababa po yung cup disc ratio. So, siguro po around 0.3 or 0.4 po.
What about the left eye?
For the left eye po is much higher. So, yun
Mga
baka
ilan
po
yun?
more of 0.8 po yung na-describe ko po earlier.
Okay, so normal is 0.2 to
Up.
0.5. 20% to 50% of the whole nerve is made out of the cup. So this one
Yes
is
po.
about 80% or 90%. Definitely there's something wrong here. So this is glaucoma in contrast to papilledema. Papilledema, baliktad naman. The cup disc ratio becomes really small. And you have cup disc ratios of 0.1 or non-existent cups in papilledema when you have increase in intracranial pressure. So very good. Okay, let's move on. Jarrell, what is this? So we did the gonioscopy, and the gonioscopy looks at the what? Jared. Nandiyan ka ba? Or anyone? So this is a procedure we call gonioscopy. We put a lens in front of the eye, and it gives us a view of the what? Kasi hindi mo makikita ito when you just examine with a pen light. You need to put a lens and look at the mirrors so you can see the angles of the eye. Okay, so the angles is where we label the patient as having open angles or closed angles. So from the surface of the iris, imagine this is the surface of the brown iris, going to the periphery, you see this dark band, which we call the ciliary body band, followed by the scleral spur, then the filtering portion, or the trabecular meshwork, and then your Schwalbe's flank. So is this angle open or closed? Jean Burgos. Jean, take a guess. Open ba ito or closed? Dalawa lang naman yan. Or anyone? Raz, Marie. Okay, just guess. Educated guess. Okay, bilisan nyo. Marami pa tayong slides. Yeah, Bianca. Is this an open angle or closed spot?
I think po this is open angle po since all of the bands are seen. Kasi po pag
Okay.
close, usually only the Schwalbe's line or no bands at all should be seen po.
Correct. Okay. Pang resident knowledge na yan. Very good. Okay. So this patient has open angles. So patient's pressure is high, optic nerve is cupped, and then we did the visual field. Yeah, Bianca, can you describe the visual field on the left eye? Which eye is normal, left or the right? So pinagawa natin ng visual fields exam sa eye center. So this is an automated visual field printout. Can you describe the visual field of the left eye? This is how the patient sees the world. So for the left eye, this is how they look at it. The right eye, this is how they, and that's how the visual field printout is presented. So you will see that the blind spot of the right eye is on the right side because the nerve is on the basal side. Okay, is this normal? Yeah,
Look for this one po, guess ko lang po. Pero
yes.
from what I know po, dapat po yung makikita po dito is more light po. So yung left eye, mas marami yung parang blind spots niya po because mas marami yung dark areas po.
So how do you describe the left eye visual field? Is the right eye normal?
Yes, Doc, I think the right eye po is
Okay.
normal.
So
Well,
it's
sa left
normal.
eye po.
Correct. It's normal, and it's also normal to see the physiologic blind spot. The left eye is what we call tunnel vision. And this is usually seen when the glaucoma is advanced. It correlates very well with the anatomy of the nerve, where you have advanced cupping and you have also advanced visual field loss. So the diagnosis, we'll go to that later. Okay, so remember, when you see a star, remember the slide. Okay, so glaucoma is a progressive neurodegenerative disease. It results in visual field disturbance. It's irreversible, and it leads to high pressure or unphysiologic pressure leads to death of retinal ganglion cells. There is usually the characteristic optic nerve cupping and a corresponding visual field defect. So without these things, you cannot label the patient as having glaucoma. So as we said, glaucoma, there is a characteristic cupping. See, the arrow points to the notching here below. And whenever you see the visual field, it's usually the reverse of what is happening anatomically. So this is the right eye there. And because the notching or the thinned out area of the nerve, the damaged part of the nerve is located inferiorly, then it leads to a superior arcuate defect. So baliktad siya lang. Okay. So what is necessary for a diagnosis? Because you cannot just make a diagnosis based on pressure or nerves or visual fields. There has to be an abnormal eye pressure. Any pressure that is too high for the eye, it can be normal pressure. That is too high for the nerve, it will lead to visual field defects and cupping and visual field loss, and you need to satisfy 2 out of 3, at least. It is gradual, progressive, and we are talking about open angle glaucoma. So who are the glaucoma suspects? These are patients with no glaucoma. Pressure is suspicious, 25, 30. Suspicious nerves, suspicious visual field damage. Sorry. It is suspicious because it's not accompanied by any other finding and may convert to glaucoma. And it only satisfies 1 out of 3. If it does 2 out of 3, then you label it as glaucoma. Okay, true or false? I have a glaucoma suspect. If my eye pressure is normal, visual field, we have a nasal step, and a cup disc ratio of 0.2. True or false? Will you consider me a glaucoma suspect? With normal pressures, a nasal step, visual field defect, and a cup disc ratio of 0.2. Anyone? Anarisa? Normal pressure, nasal step on visual field exam, and the cup disc ratio of 0.2. Is this glaucoma or glaucoma suspect? Marielle? Or anyone? It really is. Oops. I could not see the chat. Please answer. Anyone? Normal pressure. Pressure is normal. Cup disc ratio is normal. Visual field is abnormal.
True po, Doc.
Okay. So this qualifies this patient as being a glaucoma suspect because only one of the two is satisfied. Okay. So remember, you need to satisfy 2 out of 3. And in this question, you only have 1 out of 2 because the pressure is normal, cup disc ratio is normal. Okay. Slides. Slides. Oh. Okay. Yes. Do you have any questions? I'll just reshare this. Okay, so who are at risk? These are patients with a family history of blindness, especially blindness with glaucoma, diabetics, near and farsighted. So nearsighted eyes are at risk of getting angle closure glaucoma. Sorry. Let me correct that. We'll just elaborate this later. Okay, erase. Nearsighted are myopic eyes, and they are at risk in getting open angle glaucoma. Farsighted eyes are hyperopic eyes, and they're at risk in getting angle closure. If you're taking steroids, you lost a lot of blood, that makes your nerve weak. If you have an injury If you're a smoker, you have thin corneas that are at risk. So there are 4 types. One is a primary open angle, primary angle closure. Then you have secondary glaucomas. You have identifiable causes, steroid-induced, trauma, surgically induced. And these are the corresponding eye pressures. So you will see that the secondary glaucomas can go as high as 70. The angle closure glaucoma can go as high as 70. Childhood glaucoma can go as high as 70. But the primary open angle glaucoma usually stays below 50 or 50. Okay. So history taking, make sure that when you rotate in OPHTHA, few months, okay, you observe the patient. And if they have difficulty walking, they're probably you need to refer to ortho or any other subspecialty. But if it's vision, then you know that there's some problem with visual field or visual acuity. Observe and ask how the handicap is affecting the mobility, detailed history of the chief complaint, ask comorbids, eyeglass wear, family history, medications, trauma, and previous eye and systemic surgeries. The visual acuity is very important, and the refractive status, as we said, hyperopic eyes are at risk in getting angle closure. Myopic eyes or nearsighted eyes are at risk in getting open angle. And we usually follow a systematic evaluation of the visual axis and the peripheral vision. So from front to back, we think about the structures of the eye and what most likely is the cause of the blurring of vision. And remember, we do the series of exams, slit lamp exam, pachymetry is very important because this is a way of measuring the thickness of the corneas. We check the pressure by tonometry, we do gonioscopy to check the angles, and we check the nerve and the visual field. So it's a series of tests. Patients usually stay in the clinic for about 2 to 3 hours, and we make sure that they are not rushed, especially for very subjective tests like visual field exams. It has to be reliable. So here's my fellow looking at a patient, and this is how the slit lamp looks. The doctor is the one in blue, the patient is black, and it is nothing but an uprightly placed microscope to look at the eye with a slit beam so that we can do a cross-section of the clear ocular structures. We are also expecting you to know how to do digital tonometry, although this is only an estimation, it's not accurate. The normal is like the tip of the nose, and we label it as firm. But more accurate way of checking the pressure is using the tonometer. We call it the Goldman applanation tonometer. You see the arrow here pointing to the device that is attached to the slit lamp. And when you look through the oculars, you will see the semicircular mires. They're green in color. And the knob on the right points to a number that if multiplied by 10 gives you the intraocular pressure. So in this patient, pressure is about 30. And this is how the prism comes in contact with the eye. We use a blue light and we put a drop of fluorescein to illuminate the dye. So again, normal is 10 to 20 or 21. And it is influenced by corneal thickness. The corneas that are thick usually require more force to applanate or flatten the cornea. Therefore, it will give you falsely high pressures. Corneas that are thin will give you falsely low pressures. So madali lang tandaan, manipis, falsely low, makapal, falsely high. And we use the pachymeter to measure the corneal thickness. So here's just an illustration of what we do when we check the mechanism of glaucoma. We put a lens. This is the cross section of the cornea. And the lens is the one here that looks like a trapezoid. And there's a mirror on the side when viewed from the slit lamp, gives us a good view of the angle structures. And the main reason why we do this is to overcome total internal reflection. So that's a physical phenomenon that we need to overcome. And once we identify the mechanism of glaucoma, it serves as the basis for a treatment plan. So without gonioscopy, we can make mistakes in treating glaucoma. So we need to do gonioscopy in all our glaucoma patients. So here's a mnemonic. So on the right side of the photo, you will see the gonioscope with mirrors. There are 4 mirrors, and it can give us a view of the 360-degree angle. This is the mnemonic from most posterior to most anterior. Ciliary body band, scleral spur, trabecular meshwork, and Schwalbe's line. This is an open angle. However, a narrow angle looks like this. Open angle below, above there, the arrow pointing to some of the structures seen, not all. You see the iris is convex in configuration, while the open angles, the iris is usually flat configuration. Okay. Okay, so optic nerve exam is very important. And ophthalmoscopy is an important skill that is part of your EPA. So you need to practice and practice so you can see the optic nerve and make a diagnosis correct. So it is best done using the slit lamp with a fundus lens because it gives us a magnified view that is stereoscopic. And you can take photos so you can examine the nerve in more detail at your own pace. So you can use your ophthalmoscope, the direct ophthalmoscope, or the indirect ophthalmoscope. And the most reliable way of doing it is using the slit lamp with a fundus lens. So here are the things that we need to discuss. When looking at the optic nerve, we recognize the normal findings, of course. We have to know if the cup-disc ratio is enlarged. We need to know if the isn't rule is violated. I means inferior, S means superior, and nasal and temporal. And we need to see if the blood vessels are nakahubad, or we call it bearing of the blood vessels. When the nerve recedes and gets atrophied, your blood vessels are left hanging and called bearing of the blood vessels. We need to see if there's blood, notching, nasalization, and when we track patients through time, we need to see if the cupping is progressive, which is a hallmark of primary open angle glaucoma. Okay, so we showed this picture and it was accurately described as normal for the right eye, abnormal on the left. Okay. So here are some of the things that we need to see for this patient. The vertical cup-disc ratio is determined by dividing the diameter of the red line or the cup over the diameter of the whole nerve. And in this patient, the cup-disc ratio vertically is 0.8. We have notching here and bearing of the blood vessels. The nasal nerve, nasal rim is usually thickest, followed by the superior, and followed by the temporal and the inferior. So it violates the isn't rule kasi bali-baliktad ng order. So in normal eyes, you will see that the thickest one is the I, followed by the S, followed by the N, and the T, ISN. And you will also see disc hemorrhages in glaucoma, both these patients and cupping. And you'll see these are the features of glaucoma patients on pictures A, B, and C. Okay, so here is a picture of how progression looks like. You will see that from 1992 to 2003 tracked this patient using optic nerve photos. You will see that the cupping is worse in 2003. So visual field exams, in your 8-part eye exam, we teach you to do confrontation test, but the more accurate way is to do your automated visual field exam. And this is how it looks. See that the inferior notching corresponds to the superior arcuate defect. Okay, and just watch YouTube videos on how to do your confrontation test. But these are the machines that are available at our eye center. We particularly have the octopus perimeter in our eye center. Okay. So typical visual field changes, you will see that it respects the horizontal meridian. And you will see here the Jerum's scotoma, letter B, letter B sidal scotoma, Jerum's scotoma, which are very typical of glaucoma. You see the Jerum's scotoma, letter D, is connected to the blind spot. So the dark area is the blind area of the eye. And it ends on the horizontal line. So it respects the horizontal meridian, which is typical for glaucomatous visual field losses. So we know the answer to this. Glaucomatous field defects respect the vertical meridian. True or false? Answer is false. Neurologic defects respect the vertical meridian. That's why you have your bitemporal hemianopsia. And for glaucoma, you have this Jerum's scotoma. Okay. Corresponding to the inferior thinning of the nerve. So if you see this bitemporal hemianopsia, you usually think of a cellular tumor or pituitary adenoma. And it respects the vertical meridian. Glaucoma respects the horizontal meridian. So we're at the end of part 1. We're on time. Any questions? Okay. So we go now to part 2, which is the pathophysiology. And it's one of the top 3 causes of blindness in the Philippines. We need to understand aqueous humor dynamics and its effect on the optic nerve. Essentially, if you build up pressure in the eye, it presses on the optic nerve and it kills the axons and leads to visual field defects. If uncontrolled, leads to total blindness. It's permanent. So here's just a video showing the pathway that aqueous takes from its production with the non-pigmented ciliary epithelium to the posterior chamber, through the pupils, and eventually exits through the trabecular mesh. So you will see here in a normal eye with normal vision, there. So here is your ciliary body, goes through the pupil and out through the trabecular mesh. So remember that. So in glaucoma, what happens? When the pressure is high as a result of build-up of volume and stagnation or flow, resulting in increased intraocular pressure. So this is the normal flow. That is your ciliary body band. Ciliary body. And you see this glowing red part is your diseased trabecular meshwork, which prevents the outflow of aqueous and leads to build up of fluid, eventually The blockage leads to increased intraocular pressure that translates into optic nerve damage and visual field loss. And this is irreversible. So again, just skip that. So what will your patient tell you? These are some chief complaints that I've compiled over the years. I bump into things, can't drive well, progressive lenses don't work. I always hit the glass of water. I can't see part of your face. It's difficult to use the stairs. I only see the wall clock. I do not see the wall. Vision is still 20/20. No headaches, no pain. I am nearsighted or myopic. Parang may nakatakip sa paningin ko. So how do we treat? For mild cases, we use eye drops, we use laser. For moderate, eye drops, laser, sometimes surgery. For severe, eye drops, give everything to the patient. And as a last resort, we do cyclophotocoagulation when the eye is almost blind and is painful. So how do we know if it's mild, moderate, or severe? We do the visual field exam. And there are guidelines that we follow to label the visual field as mild loss, moderate loss, or severe loss. So what do we give? Medications. So review your pharmacology. You have your pilocarpine, and you put an X mark as a contraindication. So don't give it in patients who are myopic. Do not give timolol patients who have bronchial asthma, heart blocks, because they are beta blockers. Do not give brimonidine in children under 2 years. Do not give dorzolamide or carbonic anhydrase inhibitors if they have sulfonamide hypersensitivity. And these last three are prostaglandin analogs, latanoprost, limatoprost, travoprost. You do not give it in patients with swelling in the eye, such as macular edema, or even pregnant women, patients with uveitis. If you need to give it and it's safe to give, you have to warn the patient that their lashes will grow, thicken, and become more curled, and they'll develop raccoon eyes. So you'll have to make sure that they are aware of this, because they will take the medicine for life. It's like taking antihypertensive medicines for high blood pressure, okay? So lasers, this is one of the front or first line treatment that we give for primary open angle glaucoma. We call it SLT, or selective laser trabeculoplasty. It's only in the last 6 years that they've changed the paradigm from eye drops first to include now SLT and eye drops as first line treatment for primary open angle glaucoma. So we put the drops. These are anesthetic eye drops. We sit the patient at the slit lamp. We put the lens. We aim for the trabecular meshwork. And it delivers a certain amount of energy, just enough to stimulate chemotaxis and not burn tissue. And the chemotaxis will attract macrophages from the spleen to the trabecular meshwork and clean it out and allow more drainage of aqueous. So it's a very novel mechanism of action. It's effective in about 85% of patients. So no treatment is 100% effective, but because it is quick, it is easy, it's painless, there's no downtime, and it's covered by PhilHealth, a lot of patients easily say yes to this procedure. But it also needs practice and training for you to do this. And of course, you have to have access to a facility with this kind of laser. So again, it's given as first line for patients with mild to moderate disease. If there is advanced disease, then we consider doing surgery. So when the scarring potential is low, it means the eye has not been operated on, patient is elderly, and the amount of fibroblast formation is not as much as young patients or those patients who had previous surgery, then trabeculectomy will be the procedure of choice. So here is a sample of our surgeries. So we open the conjunctiva, we enter the anterior chamber, we punch a hole and create an artificial canal for aqueous to drain out of the anterior chamber. And then we close the conjunctiva and monitor the patient. So that is trabeculectomy. Now, if the scarring risk is high, that means that we create a canal and the body just closes the canal with scar. Then we put in a tube. Now, it's a silicone tube connected to a plate, and the scar can form around it, but the silicone tube remains patent. And it's also a very effective procedure in patients who had previous surgeries, whose trabeculectomies have failed, and it lasts for many, many years. So we have to put in a device, and you see, it looks like a mouse. And you have the plates that regulate exit of aqueous and keeps the pressure between 10 to 14 millimeters mercury. So this procedure is available at our center, and takes about an hour to do the procedure. Okay. As a last resort, in very advanced cases, especially in painful blind eyes, we have to kill the ciliary body by exposing it and coagulating with a strong energy from a diode source, and we call it transscleral cytofocal photocoagulation, or diode TS-CPC. Okay, so let's go back to the case. This patient is a 51-year-old male, frequently bumping into things. These are added information for you, so you can make a diagnosis. Here's the pressure, abnormal on the left. There are the nerves, open angles. So your diagnosis here is visual field, primary open angle glaucoma. Advanced on the right, advanced on the left, normal on the right. Okay. So again, we go to the 4 types. We're done with primary open angle glaucoma. We go to primary angle closure. So can anyone diagnose the pictures here? Or just describe what you see? Xavier. Yeah, first picture on the left, Xavier. Deltran. So you go to the ER, you go on duty, and 3 patients showed up on your duty day. First patient looks like the one on the left upper. Second patient, middle picture. Third patient, upper right. Xavier.
Hello po, Doc. So, yung sa pinaka-left po na picture, so
Upper left, yes.
yes po. So the eye po is diffusely red, tapos mukha pong parang nagba-bulge po yung kanyang iris po.
Okay.
Tapos yung middle picture po, para po may opacity po sa iris. And then the third po, parang ganun din po, like may redness po sa sclera po. And then yung parang nagkaroon po ng tear po yata sa iris.
Okay. At least you're correct with the redness. Definitely, they are not normal. And what sets all these each of the photos and cases apart from each other? Ano napapansin? So pareho lang silang mapula. Ano yung nasa gitna dito? Yeah, yeah, yeah. What do you call that? Anyone? Or a savior? Si Jarlene naman. Sa lang daw. Jarlene? Are you there? Yung nasa
May
gitna. Yes.
sa gitna po, parang may
Yeah.
hazy cornea po. Tapos may
Okay.
parang light beam siya po do.
Mhm.
So, I think this could be a sign of obstructed anterior chamber view po.
Okay. So ano itong bilog na nasa gitna ng lahat ng photos? Yan. What do you call them? Jarlene. Here. Yung bilog na yan. Ah, itong bilog. Bilog. Ito bilog dito. Yeah. What do you call all those things? Makikita mo ba yung photos, Jarlene?
It's the pupil po do.
Pupil, correct. Huh? So what makes the first picture different from the second and the third based on the pupil? Can you describe? Magkakaiba ba sila o pare-pareho?
May parang corneal edema po siya. Cloudy po yung cornea.
Yes. Oh, but describe the pupil.
Ay,
The pupils of the three photos.
it's dilated and
Okay. So,
fixed po.
hindi siya fully dilated. That's correct. But it's mid-dilated. Ito naman, second photo. How is the pupil here compared to the first and the third photo? The pupil.
Constricted po ba siya do?
Constricted, correct. No? Hindi lang siya constricted pero hindi siya well delineated. No? Ano to mga to? Yung mga parang irregular yung borders. Tawag doon. Dito kasi, kita mo yung borders naman niya, well delineated. Ito, mas maganda pa, well delineated. Ito mga puti-puti na to, reflection lang ng ilaw. It's true. So, how do you describe this pupil compared to this one, in terms of the border? Darling. So, anong pinakamagandang pupil dito sa tatlo? Pinaka-normal looking. First, second, or third? Here, or third? Ano pinakamaganda? Normal looking pupil.
Third po, Doc.
Third, correct. No, at least correct answers. So pag may pumunta sa ER, mapula mata, mukhang normal naman yung pupil. Very clear yung cornea. So ano most likely ang diagnosis nito? Sa third. Mapula mata, nagmumuta, pero normal yung cornea. Normal yung pupil. Normal yung iris. Anong tawag dyan? And you have conjunctival injections here. May konting discharge. That is watery. Ang tawag dyan.
Conjunctivitis po ba to?
Conjunctivitis. So if the discharge is clear and the eye is watery, the pupils are normal, cornea is clear, most likely it is
Viral conjunctivitis.
viral, correct. So ito naman sa gitna. Ano to? Parang irregular yung pupil, dikit-dikit. Ang tawag natin dito sinikya. Ano yan? Yeah. Ano yan? Can you hear me? Karen? Okay, so ano tawag dito? Pag nagdikit-dikit na yung pupil at maliit siya, mukhang may cataract pa sa gitna, that is your lens that is opacified. Here, your lens is clear. So anong tawag dito? Pag nagdikit-dikit na may sinikya, ang tawag dito is posterior sinikya. You call this? Ito muna, mid-dilated pupil, mapula mata, hazy yung cornea. We call this? Jarly.
Acute angle closure
Acute
glaucoma. Acute angle closure glaucoma.
Nasa ER sila, biglang sumakit, nagsusuka, malabo ang mata, steamy vision, masakit, taas ang eye pressure, mid-dilated pupil, correct. Acute angle closure glaucoma. Ito ang tawag dito, starting with U, as in umbrella.
Uveitis po.
Uveitis.
Uveitis
Correct.
po.
No? Correct, Cassandra. Cassandra ba? Okay. Yes. No? So, these are the three main reasons why patients will come to the ER with the red eye. Of course, there's trauma, madali lang naman yun. Subconjunctival hemorrhage, mukha siyang dugo. No? But this can be confusing. So look at the pupil. If it's mid-dilated, might be glaucoma. If it's dikit-dikit na maliit, there's a lot of photophobia. Pupil maliit, and there's synechia, uveitis. Normal cornea, normal pupil, mapula mata, conjunctivitis. Okay? So remember that. Okay? So we'll go now to angle closure glaucoma, and it's mostly unilateral. More common in females, very high in China prevalence, and in Chinese ancestry. Patients who are at risk are in their middle age. And question, I can get primary angle glaucoma if my angle closure glaucoma, if my eye grade is -6. Ano bang grade yung -6? Anyone? Primary angle closure glaucoma if my eye grade is -6, or we call it 600. -600. Ano ba yung -600? Sa optics and refraction natin. See a minus sign, it is a correction for anyone?
For myopia po to.
Myopia. So madali lang tandaan. Minus for myopia. Plus, pag may nakita kayo, plus farsightedness. Farsightedness plus. Okay. Correct. So the answer to this is
False po
false.
to.
Correct.
Dapat
False.
po primary open angle po
Yeah,
siya.
correct. Okay, very good. Okay. So when your eye pressure is very high and you have primary angle closure glaucoma, it appears close in gonioscopy. On gonioscopy, halos wala nang makitang angle structures. then you can get a cataract kasi mataas yung pressure, can damage the zonules, optic nerve damage, visual field damage, eventually blindness. Don't forget to check the fellow eye kasi eventually magkakaroon din. The main mechanism why the angles are closed is pupillary block. So remember, pupillary block, and you will see here that this is an ultrasound video of a patient who with narrow angles, when the lights are off, ano nangyayari sa pupils? Lumalaki yung pupil. And when the angles are narrow and the pupils get bigger when the lights are off, you will see that the angles encircled by the red become narrower. See? Okay, sumisikip. When the lights are on, lumuluwag yung angles. And that's why patients who stay in the dark for a long time awake, like watching a movie, with a very narrow angle can develop an attack of glaucoma when they get out of the movie house. So a more high-resolution view, you will see here on top photo, it's an open angle when the lights are on, and a very narrow angle, the lights are off below. So what your patients will tell, what will your patients tell? They're usually middle age, intermittent blurring of vision, pain, aching in or above one eye. They see halos, they're nauseated. There are trigger mechanisms like stress, financial stress, emotional, physical stress, jet lag, or watching Senate hearings that are very stressful can trigger an acute attack of glaucoma. We see that it can happen at any time of the day, and sometimes it gets better, but it gets worse again. Eventually, come to the ER for vomiting, headache, and blurring of vision. So here are the triggers. This has been identified long time ago. Watching TV, essentially long screen time and stress. And someone who has an intermittent angle closure can jump directly to an acute angle closure glaucoma, such very similar to a heart attack. First, you have angina and develop an acute myocardial infarction or stress, similar to the eye. So what happens when you have acute angle closure glaucoma? Can be destructive, lead to blindness, there's pupillary block, and very high intraocular pressure. And you see the injections are also present on the ciliary area, which we call ciliary injection. Not only do you have conjunctival injection, but it extends all the way to the limbus. And usually sudden, there's red eye, blurry of vision, as we said, nausea, vomiting. And the patient is hyperopic. So be careful with patients who are hyperopic. As they age, they can get glaucoma, acute angle closure time. So it can be very damaging. We just go through this over and over again. You see, this is a mid-dilated pupil, red eye, high pressure, hazy cornea, from corneal edema, which leads to blurring of vision, halos, a mid-dilated pupil that is vertically oval, high pressure, inflamed eye, and you have injection chemosis and lid swelling. Chemosis is swelling of the conjunctiva. So we lower pressures of the ER in a patient in acute attack. You need to make the patient feel comfortable right away by giving eye drops and systemic medications such as carbonic anhydrase inhibitors in the form of acetazolamide. You can give hyperosmotic agents like glycerin orally. You can inject a hyperosmotic agent like mannitol. But these are the things that we give at the ER level. Then we bring the patient to the eye center and we do definitive treatment like laser iridotomy or peripheral iridoplasty that looks like this. There. So we put the patient at the slit lamp attached to a laser, and we punched a hole using the laser there, relieving the pupillary block, because pupils here in this area is blocking the flow of aqueous, and the iris is bulging forward, hence you have angle closure, therefore creating a bypass on the peripheral cornea or peripheral iris, so relieves the pupillary block. Or you can contract the iris and pull it away from the trabecular meshwork. Together with doing laser iridotomy will also relieve the attack. If all else fails, then we do surgery or trabeculectomy. So any questions? Any questions related or not related? Okay, while we're taking a breather, turn on your cameras. Take a screenshot. So now the first page, we have 8 pages. Kasi tayo. Okay. So ano bang hinahanap natin sa isang medical school graduate na kakapasa lang ng PLE? And usually mga residency training programs have 2 slots, 4 slots, 8 slots. But then the applicants are like 50, 60. So what are your chances? How do you increase your chances of being one of the 2? You have 30 applicants. It's really a strategic game. Gusto niyo bang sabihin ko kung ano yung mga criteria? Parang tahimik kayo lahat. So just like last year, we had 27 applicants. And then out of the 27 applicants, we accepted 2. Both are UERM graduates. Some applicants came from Ateneo, UP, SAL, the province. Fortunately, the UERM graduates emerged as the top 2. Okay, so it's a combination of many factors. Are you interested to know that? Parang ayaw nyo ata. Sayang, kasi kung ako nalaman ko, med student pa lang ako, baka mas marami pa ako ginawa towards increasing my chances. So my heart naman ako nakita dito, baka gusto nyo. So first, jiwa. Yung pinakamasakit na jiwa. So, but not all is lost kung hindi presentable ang jiwa ninyo. Kasi that constitutes about 20% of the criteria. Next is the PLE scores. So, if you're first, second, and third year, pwede na, pero parang hindi ko pwede ilaban yung jiwa ko. Pero kung okay yung jiwa nyo, then bet on it. So, meron pa kayong magagawa. PLE. Pag-aralan nyo na mabuti yung PLE. Dapat mataas kayo sa PLE. Dapat lahat kayo pumasa. So, that constitutes about 20% of the criteria. So, may 60% pang natitira. So, it doesn't mean na kung mababa kayo sa ranking, baba yung G1 ninyo, pumasa naman, pero sakto lang. Pero mataas naman yung PLE nyo kasi pinag-aralan nyo. No? At syempre, when you go through med school, ang dami-daming stressors dyan. No? Minsan, tinitingnan nyo na lang yung transcriptions nyo. Wala nang pumapasok. Tinititigan nyo na lang kahit anong gusto nyo aralin, saturated na, no? Some of you burnt out na. So, of course, you do a lot of study techniques and yung medical school grades naman, we look at it kasi it's an indication of how good at you in self-study, less coaching, and ability to pass the diplomate board exams. Siyempre, yung tatanggapin ng mga programs, yung mga hindi kailangan turuan mag-aral, yung ini-expect namin, napapasa talaga. So, if you have developed very good study habits in your med school years, that will help you a lot. PLE will also help you a lot with the PL. It's a 60% interview. Very important. 20% is the interview. So that is where we get to know you more. That is where we see how mature you are. Si iba ang tataas ng grades, taas ng grades sa PLE. Magaling nga mag-aral, pero madaling ma-burn out. Laging nawawala. Pag hindi na sila happy, pupunta ng Schumer. Biglang nagdi-disappear. Hindi marunong makisama sa mga co-workers. Nagsasarili lagi. So dapat magaling kayong team player. Doesn't mean just for ophthalmology. Kasi you're working with a team. So when you enter your residency, you're at the lowest level of the team. First year ka eh. So if you go to surgery, medyo malakas ang hierarchy nyo dyan. So one of the most in-demand specialties actually are ophthalmology and dermatology. So talo kami ng dermatology. They can reach about 50 applicants for only 2 slots. And that's true for all programs kasi ilan lang sila accredited by the Philippine Derma Society. So OPHTHA, there are about 28 programs all over the Philippines. Derma, much less. So if you're a good team player, you have good extracurricular, you are a survivor, you have the grit, you survive any kind of challenge, masyado nagpapa-apekto ng intriga, trabaho ka lang, no? Magaling ka sumunod ng mga rules, you are very good in relating to your co-workers, your non-health, non-medical staff, guards, mga manals, secretaries, and you are trainable at napapagsabihan ka, lumalabas lahat yan sa interview. So, tinitingnan din namin yung mga letters of recommendations ninyo. And it has to be a very meaningful letter of recommendation. Hindi kayo pwede magbigay lang ng template sa isang kakilala niyong professor and then you ask the professor to sign it. Kasi wala kaming masusulat doon eh. So how do you work towards having a very meaningful, strong recommendation? Mag-shadow kayo. Magpakilala kayo sa mga professors. And not all, but some will allow you to shadow. During your summer breaks, during your downtime, sipagan nyo lang. You really have to outdo all the other candidates, all the other applicants. You have to out-hustle them. Kasi yung iba kasi, ay, ayoko naman mag-shadow, hustle lang yan. Manunod na lang ako ng sine. Habang yung iba, nagre-research, nag-attend ng mga conferences. So if your path is OPHTHA, attend na kayo ng mga conventions as early as now. Pag meron kayong free time, manood na kayo ng mga videos, mga recorded conventions. Get to know the specialty more. And you immerse yourself in the specialty, more especially research. Kasi research is a very strong currency when you apply for residency. Kung pwede nga mag-gap year pa kayo, mag-enroll kayo in Masteral Clinical Epidemiology. Kasi walang gustong gumawa doon dahil aral na naman yun eh. But if you get a masteral degree in research, and you have some publications. As a first author, hindi yung taga-Xerox lang kayo. Dapat first author kayo. Kayo nagsulat lahat. From the title, to the protocol, to the methodology, introduction, analysis, to the discussion, conclusion, at pinablish niyo pa. No, kahit hindi masyadong presentable yung G1 PL, pero sobrang lakas niyo sa research. But how to hook up with research projects? Maraming ways. Just have to go to the internet. You can do researches with DOST. And right now, we're already advertising that we are accepting a research assistant for our research in ophthalmology. So you'll be teamed up with a resident, and you'll start out with meetings, write-ups, submitting the research project to the IRB, and dapat sumama kayo as early as IRB approval kasi that's the only way you can be part of the authorship. Kasi kung sumama kayo at tapos na yung IRB approval, nandun lang kayo sa acknowledgement. So, of course, meron kami interview. If you want to be a research assistant, dapat merong grade cut-off. Dapat hindi napapabayaan yung studies ninyo. And then you can focus on your studies as well as do well as a research assistant. So starting last year, we already accepted one, and she completed a research project with our department. So every year we accept one, but if there are more research projects, we accept more than one. So all you need to do is, if you have time, medyo mabigat ang third year, pero kung okay naman grades ninyo, hindi nyo isa-sacrifice yun at hindi kayo naghahabol, baka pwede. Because we advertise it to first years, second years, and third years. Mas mahirap sa third year kasi very heavy at load. Pero kung kaya nyo, then just make sure na hindi nyo pabayaan studies. Any questions? May naiwan pa. No? Pre-residency. So that is 1 month of shortlisting the applicants, maybe from 30 down to 5. And then 5 kayo, for 1 month residency. Then you'll be observed, you'll be graded. And then the 2 who emerge as the top ones, overall, will be accepted. And there's the psych exam. Psych exam on UERM. And to make sure that we also look after your mental health. So overall, yeah, that is the overview of application for residency. So not all will be interested in residency. For those of you who want to follow a track in the academe, you don't need to be a resident. All you need to do is take up masteral studies in medical education. Para maging faculty kayo ng anatomy, biochem, parasitology. Because the College of Medicine is in need of faculty, but we need masteral holders. So you don't need to be an ophthalmology resident, be faculty. If you want to teach the basic medical education, just take masteral in medical education. If that's the track you want. Okay din siya. Kasi some people really like cheating. Okay, any other questions? Kung wala, we'll go back to the lecture. Nalihis na tayo. We go back to the lecture. Okay. Short break. Tumagal na yung short break na sila. Any questions habang so, marami na ba kayong stars na nakita dun sa slides? Sorry, hindi ko mahanap. Are you still seeing the screen? Hindi ko mahanap yung screen. Just stop share. Okay. Sure. Okay.
Dumulog po sa GMA Kapuso Foundation ang isang lalaking nagmodelo sa murang edad dahil ulila ng lubos. Nagturok umano siya ng steroids para lumaki ang katawan pero ngayon hindi na maaninag ang nakasanayang spotlight dahil sa panlalabo ng mata. Makakatanaw pa kaya siya ng pag-asa?
Sa loob ng ilang taon, nasanay ang 29 years old na si Mads sa mga pitik ng kamera at spotlight sa entablado bilang isang modelo. 5 taong gulang pa lang, ulilang lubos na si Mads. Kaya para matulungan ang pamilyang kumupkop sa kanya, maaga siya nagbanat ng buto sa edad na 16.
Nag-start po yun yung nagtatrabaho po ako ng waiter hanggang sa kinausap ako ng may-ari ng bar na mag-stay ako gawing modelo nila.
Para makakuha ng maraming modeling projects, nagturok daw siya noon ng steroids para gumanda ang kanyang katawan. Yan ay kahit pa nakararanas na raw siya ng pananakit at panlalabo ng mata.
Mga pageant po, marami po kasamahan na nag-i-steroid. Malaki pong pagbabago sa katawan ko. Kaso sa loob ng 3 buwan, nag-iba po yung paningin ko na. Umina na, nawala na po ang tuluyan.
Dahil sa kanyang pagsasawalang bahala, tuluyan ang hindi nakakita ang kanang mata na sinundan ng kaliwa niyang mata. Para maisalba ito, agad siyang nagpa-opera noong 2019. May kaunting liwanag pa raw itong nakikita, pero madalas sumasakit dahil wala siyang pambili ng gamot.
Napansin ni Mads na itong nakaraang mga buwan, yung mga hugis na nakikita niya unti-unting nawala, na naiwan na lang yung ilaw na lang. At mukhang ang dahilan doon sa paningin, yung pagkawala ng paningin niya, glaucoma rin, dahil maganda naman yung pagka-opera ng cataract at nalagyan na rin siya ng tube implant para sa glaucoma.
Lumapit si Mads sa GMA Kapuso Foundation at umaapela ngayon ng tulong.
Sobrang malaking pagsisisi po. Sana matulungan po nila ako.
Posible kayang naapektuhan ng steroids ang kanyang mata? Sa pagdiriwang ng World Sight Day bukas, abangan muli ang pagpapatuloy ng kwento ni Mads.
Okay, so that is just an introduction of how secondary glaucomas can blind. There are a lot. Secondary means there's an unidentifiable cause. Okay, so it is a result of many things. Can be from neglected mature cataracts. So yung sinasabi nila, pag pinahinog nyo yung cataract, manganganak ng ibang problema niya. Magiging glaucoma na mauwi sa permanenteng pagkabulag can be a result of accidents to the eye, getting hit by the shuttlecock of a badminton game can cause glaucoma. Taking steroids, inflammation, surgery, diabetes. So all those are identifiable causes. So can anyone tell me what is wrong with this baby? Anyone? Volunteer? We only have 18 minutes to go. Madali na lang po. Anyone? Which eye is the problem, or is this a normal child with normal eyes?
Hello po, Doc.
Yes, Avery.
Yung eyes po niya are asymmetrical po.
In what sense?
Yung left eye po niya is bigger than the right eye. Left eye is bigger than the small eye, the right eye.
Okay, so that's a correct observation. It can also be that the right eye is smaller than the left eye. So you need to check the eye very well, but correct, there's something wrong with the eye. So because babies are nonverbal, we have to rely on our diagnostic skills that are mainly visual. There are visual clues that will tell us there's something wrong with the baby. So when you catch babies in the pedia rotation, look at the eyes, look for symmetry, and refer right away to ophthalmology if you detect a problem. So this is childhood glaucoma. It is rare, but it is more common in patients who are born in consanguineous marriages, such as those born or living in the Middle East. So marami dyan. Consanguineous marriages. It results from angle dysgenesis, mainly trabecular dysgenesis. That means there's a factory defect. The trabecular meshwork did not develop fully, and hence aqueous has difficulty getting out of the eye. So here are photos of our patients who we subject to examination under anesthesia. Upper left photo, you see we put in a lens with a speculum, with a lens, and this is what we see. So this is a special type of gonioscopic lens to look at the angles and to explain the mechanism of glaucoma. So you will see that no angle structures are seen. The iris is inserted high above the trabecular meshwork, and on histopathology, there is trabecular dysgenesis. So it's very important to observe the child. Making it simple, you just have to know if the corneas are enlarged, if the pressure is high, and you look inside the eye, and if the nerve is cupped, this is pathognomonic and is the most reliable sign of glaucoma in children. Not increased ocular corneal diameter, because there's such a thing as megalocornea. Not elevated intraocular pressure, because the child can have high pressures when they are crying, but when you look inside the eye and the nerve is cupped, that is the most reliable sign. And the good thing about children is that the cupping is reversible. That means that if you lower the pressure, the cupping goes back to normal if you catch it at the right time. So what are the symptoms? There's the triad of tearing, photophobia, blepharospasm as a result of the high pressure. The cornea is swollen, and therefore that causes the photophobia, tearing, and the squeezing of the eyes. So here is a patient. You will see that the corneas are enlarged. There's this whitish discoloration of the cornea, which is a manifestation of a break in the Descemet's membrane because the eye is stretched. So these are stretch marks on the cornea. And you see that the child is manifesting blepharospasm, photophobia, and tearing, and even at room light or indoor light, child cannot tolerate the light. Now, this is a close-up view of how a HAP stria looks like. You see this horizontal streak that is a representation of a break in the Descemet's membrane. Because the eye is stretched out, the Descemet's membrane snaps, and you will see that as a striae, coupled with enlargement of the cornea, cupping, and high intraocular pressure. So just for you to capture a mental image of how congenital childhood glaucoma looks like. So when you see anyone in the nursery or pedia department whose eyes look like this, you need to refer the patient to ophthalmology. Now this baby on the left upper hand of your screen looks normal, but if you measure the cornea, both are enlarged. So you will see that this is a patient who we caught very early in the disease. 1 or 2 months of life, we caught it right away. That's why we were able to intervene, and now the patient is an adult. But if you catch these patients with opaque corneas, that means that glaucoma has been happening even in utero, and there's very little you can do about this. So these are the ideal patients that you catch, corneas that are not too cloudy, and you can do so many things to save their vision future. So this is a close-up photo of this baby. You see that the iris is still visible, but see the corneal surface is rough, very rough because of the high intraocular pressure. There and many other photos, children that we've seen over the course of my practice, from this patient with very large corneas, normal left eye, this patient with opacified left eye with large ophthalmic eye. We call it mata ng baka. So ox eye, kasi you don't see any white part of the eye anymore. Everything is black. So this patient, left eye is abnormal. This patient, very subtle, but we see that one eye is also abnormal. Here, one eye is bigger. Here, definitely, you cannot miss this. Here also cannot miss this one, and the last patient here is in her teens. You see that the corneas are enlarged. Okay, so here's this baby who we operated on. This is pre-op. This is a little bigger. Post-op, we see the corneas are clearer after surgery. So childhood glaucomas are surgical diseases. Eye drops are just meant to temporize treatment while waiting for them to obtain clearance from the pediatrician. So once they get cleared, we do surgery on them and watch them very closely for life. Okay, do you have any questions? We're on time, we're 10 minutes early. Any questions? Let me just take a screenshot of your attendance. Oh, you just have 10 minutes to think of questions related or unrelated to the topic. If there are no other questions, we will end early. New message. So what kind of surgery do you do in childhood glaucoma? We still have time. Let me see if I can share screen. We do trabeculotomy. If in adults, we call it trabeculectomy. In children, we call it trabeculotomy. Ano paano? Let's look for Hey, can you see my screen?
Yes po, Doc.
Okay, so this is an answer to the question of what kind of surgery do we do for pediatric patients. So this is a goniotomy. It's a much simpler, more elegant procedure. This is what we do in children. We put a lens and then we incise the trabecular meshwork. It is a very effective procedure, especially when the corneas are clear. So again, for those of you who missed it, we put in a gel inside the eye, we put in the lens, put a small knife inside, cross it over to the other side, and then we incise trabecular meshwork under general anesthesia. Okay, but some more modern ways of doing it is to insert a proline suture to the trabecular meshwork inside the Schlemm's canal there, and then we allow it to exit 360 degrees away, and then we pull it to rip the trabecular meshwork, and it opens the trabecular meshwork. So this is an actual video there. So we insert the proline suture until it goes around 360, and then we pull it out, ripping away the trabecular meshwork and exposing the drainage channels of the eye. Another surgery when the corneas are cloudy, then we cannot see the trabecular meshwork. We insert a 6-0 proline suture. Sorry. Then we push it around the Schlemm's canal, and then we pull it, and it rips away the trabecular meshwork. Or a better, more elegant way of doing it is to insert a fiber optic catheter with a blinking LED light, so we know where it is. You see the blinking LED light there. Then once it comes out, the other side, we pull it out and it rips the trabecular meshwork. There we pull it out, see? And then there's some blood. Then we monitor the patient post-op. Thanks for the question. I didn't think we have time. I didn't anticipate that we'd end early, but that's added information for you. For those of you who'd like to take care of children with glaucoma for the rest of their lives, this is the specialty for you. Any other questions? I'm looking at the chat. We have 3 minutes to go. I think we answered it. How big of a component is our grades for residency? It's 20%. Now, if you want to train abroad, you need to take the MLE. If you want to have hands-on surgery, supervised, like what I did in Boston, we were able to do surgeries on patients as a primary surgeon, but you need to pass the MLE in order for you to obtain a limited license in Massachusetts. So you cannot operate elsewhere, but in Massachusetts Eye and Ear Infirmary, if that is your designated hospital. But as I said, if you're not fortunate to pass the MLE, you can still go and get research fellowships, and that is also a good track. Some applicants take research fellowships. Eventually, they pass the MLE and they take residency there. Having that research experience builds a network of connections and makes you a very attractive applicant when you apply for residence in the US. So what we did is we took residency here, took fellowship there, and came back here. Iba pa rin sa Pilipinas. Okay, 2 minutes to go. I'm sure you have questions. Now is the time to ask. Okay, we'll end exactly a minute from now. If there are no other questions, magtitingin na lang tayo. But good luck in the exams. Make sure that you have a good study schedule, focus, and stay healthy. Don't want you to miss your exams because of illness. So yung hirap habulin. Okay, again, if you're interested, we have applications open for research assistant, and Dr. Paul Gomez is our vice chair for research. He will entertain applicants, okay? So I hope you enjoyed the lecture. You have 30 seconds to go, and wish you all the luck. If you need to approach us personally, please don't hesitate to visit the department or contact our department secretary and we can arrange something. Okay, take advantage of your faculty because we're here to share, make it a very nurturing environment. Okay, if there are no other questions, thank you for listening. I hope you learned something today. I'm happy to share what I know, and hopefully you can make it better when it's your time to practice. Okay, bye-bye, everyone.
Thank you, Doc.
Thank you po, Doc.
Okay, good luck.
Thank you po, Doc.
Thank you po, Doc.